Hello guys, welcome back to Medico Days. So, this is my preview of the Neetpg subject-wise edition of Medico Days Notes of 2026. As you all know, Medico Notes 2025 was mainly a rapid revision book and I'm extremely grateful for the huge support from last year's students. Based on your feedback, this time I've created 3 different formats to suit every type of learner. So in this video, I'll be discussing the subject medicine. Each of the subject which I'll be uploading in my upcoming videos will be done in this format. The first one is the workbook or the test format. So you can practice like a real test. Only the question and the options are provided, and finally you will have the answers provided. Now the second set is the rapid revision format. Quick and high yield revision is provided in this section. And next is the third one where there is, moving on to the third section. Let me take it. So this comes in the last section where you will be having extensive edition format, that is detailed explanation for deep understanding. So please let us know if you find this useful and whether you'd like the same format for other subjects in the upcoming Neetpg 2025 edition as well. So your feedback truly helps us improve. We are planning to launch the volume 1 of the book on Jan 21st, and there will be total of 2 volumes. The volume 1 will contain the medical subjects and volume 2 will contain the surgical subjects. Volume 2 we are planning to launch by Feb 2026. So the older version, which is from the 2017 to 2024 Q Bank of all the PYQs, is still available for purchase through our super profile link, and I'll be providing the link in the description. Also, all Neetpg PYQs from 2017 to 2024 solved year-wise are available in our membership video as part of the yearly subscription. And guys, thank you once again for your support, and I hope this new edition helps you in your Neetpg 2026 journey. Now moving on to this video. So a patient came with complaints of palpitations and dyspnea for 4 hours. On ECG, he was found to have atrial fibrillation with no other cardiovascular symptoms. What is the next best step in the management? So yes guys, so this here the options are ventricular rate control, emergent cardioversion, then look for left atrial thrombus with carotid Doppler and anticoagulation. So guys, make a guess what is the correct answer. So yes guys, here the answer is ventricular rate control. And the patient is hemodynamically stable with no hypotension, chest pain or heart failure symptoms. In stable atrial fibrillation, the initial step is to control the ventricular rate using beta blockers or calcium channel blockers. Cardioversion, that is electrical or pharmacological, is reserved for patients who are unstable or have an AF less than 48 hours duration after excluding the atrial thrombus. And anticoagulation is indicated based on the CHA2, DS2, VAS score, but it is not the immediate next step. Looking for left atrial thrombus is done before elective cardioversion if AF is more than 48 hours or unknown duration. Next, a 40-year-old woman presents with dry eyes, dry mouth and dry cough. She requires frequent sips of water while eating. Shermer's test was positive. Lab investigations revealed ANA, anti-Rho and anti-La antibodies. What is the characteristic feature seen in this condition? Answer is destruction of salivary gland and lacrimal gland due to lymphocyte infiltration. So the clinical features here strongly suggests Sjogren syndrome. It is an autoimmune disorder with strong female predominance. Lacrimal and salivary gland are the primary targets, leading to decreased tear and saliva secretion, that is Sika syndrome. This lymphocyte infiltration and fibrosis of these patients, mainly involving the activated CD4 helper T cells and B cells, including plasma cells. Diagnosis, serological tests for SSA and SSB antibodies, often along with ANA positivity. Next, a 20-year-old patient presented with salt cravings, skin pigmentation, hyponatremia, hyperkalemia and metabolic acidosis. Likely diagnosis is Addison's disease. The presence of salt cravings, skin hyperpigmentation, hyponatremia and hyperkalemia and metabolic acidosis is characteristic of primary adrenal insufficiency, that is the Addison's disease. It results from destruction of the adrenal cortex, leading to deficiency of cortisol and aldosterone. So loss of aldosterone, sodium loss, potassium retention, hypertension and metabolic acidosis happens, and because of the low cortisol there is fatigue, weakness, hypoglycemia and low stress tolerance. High ACTH leads to skin and mucosal hyperpigmentation. So the common causes of primary adrenal insufficiency are also provided here. And the secondary adrenal insufficiency causes are also provided. Cushing's causes and pheochromocytoma, Conn syndrome causes are mentioned here. Next, a female patient with a known case of bronchial asthma is on levalbuterol and ipratropium bromide meteor dose inhalers. She now reports frequent nocturnal symptoms including wheezing and breathlessness that wake her up several times a week. What is the most appropriate next step in the management? Answer is add LABA and inhale corticosteroids. So the patient has poorly controlled bronchial asthma evidenced by frequent nocturnal symptoms and wheezing several times per week despite being on short-acting beta agonists, that is SABA, and anticholinergic, that is ipratropium therapy. According to the GINA guidelines, that is the Global Initiative for Asthma Stepwise Management, next step is to add a combination of LABA and inhaled corticosteroid. Inhaled corticosteroid helps reduce the airway inflammation while LABA provides long-term bronchodilation, controlling the nocturnal and persistent symptoms. Next, a patient is newly diagnosed with HIV and has had fever for 2 weeks with cough and dyspnea. Chest X-ray showed cavitatory lesions in the upper lobe. Patient is to be started on treatment. What is the appropriate strategy? Answer: start ART after 2 weeks of anti-TB therapy. So the patient has HIV-TB co-infection with CD4 count of 150 per microliter. Correct strategy is to start the anti-TB therapy first, followed by antiretroviral therapy after 2 weeks. This approach allows the patient to tolerate the anti-tubercular therapy before introducing the antiretroviral therapy, and it helps reduce the pill burden, overlapping toxicities, and the risk of immune reconstitution inflammatory syndrome, that is the IRIS. So a few more details on HIV-TB co-infection and the rationales are provided here. Next, a patient who has undergone knee replacement surgery 7 days back now presents with complaints of sudden shortness of breath and tachycardia. Next, appropriate diagnostic test is answer CT pulmonary angiography. So the patient had sudden dyspnea and tachycardia following recent surgery and immobilization, which strongly suggests the pulmonary embolism. The most appropriate and confirmatory diagnostic test for pulmonary embolism is the CTPA, and it visualizes the intraluminal filling defects in pulmonary arteries, and it's considered the gold standard in hemodynamically stable patients. So Wells score is used to estimate the pretest probability of pulmonary embolism. Next, a patient came with history of dyspnea, fatigue and palpitations for 6 months. He gave a history of acute rheumatic fever in childhood. On examination, JVP was elevated irregular pulse was there, hepatomegaly and pedal edema were present. There was a left parasternal heave. On auscultation, opening snap with mid-diastolic murmur was present. All are true in this case except answer pre-systolic accentuation of the MDM is a hallmark of this condition. So the clinical presentation here suggests rheumatic mitral stenosis complicated by atrial fibrillation and right heart failure. Irregularly irregular pulse is seen in atrial fibrillation, which commonly occurs in long-standing MS due to left atrial dilation. And JVP elevation absent A-wave, hepatomegaly and pedal edema indicates right-sided heart failure secondary to pulmonary hypertension. Opening snap followed by mid-diastolic murmur at the apex is best heard in the left lateral decubitus position. It's classical for mitral stenosis, and pre-systolic accentuation of murmurs occurs due to atrial contraction, but it disappears once the AF develops. Next, a patient presents with morning stiffness and tests positive for anti-CCP antibodies. Which of the following histological features is most characteristic of the underlying disease? Answer is Panus formation with synovial hypertrophy. So the clinical feature of morning stiffness and anti-CCP antibody positivity is diagnostic of rheumatoid arthritis. Rheumatoid arthritis is a chronic autoimmune inflammatory arthritis primarily involving the synovial joints. Hallmark histological feature is the Panus formation resulting from synovial hypertrophy and proliferation. Anti-CCP antibody is highly specific, almost equivalent to 98% for RA. The histopathological features are also provided here. Next, a 30-year-old female notices weakness in her right hand and difficulty while kneading through. On examination, right arm tone and power are decreased and reflexes are sluggish. What is the site of the lesion? Answer: anterior horn cells of the cervical spinal cord. So the patient presents with focal weakness, decreased tone, reduced power and sluggish reflexes confined to the right arm. These are classical of LMN lesion. Anterior horn cell is the site of elements in the spinal cord, hence it's the most likely site of lesion. Weakness which is limited to one limb, local lesion rather than diffuse, and hypotonia plus diminished reflex limb point towards element involvement. Anterior horn cells in the cervical spinal cord innervates the upper limb. The common causes include motor neuron disease, spinal muscular atrophy, poliomyelitis, or focal anterior horn pathology. So element signs are mentioned here. Yes, the features are there. And next, a 55-year-old patient presents with shortness of breath and arterial blood gas analysis reveals the following: pH of 7.2 to PaCO2 of 66, PaO2 of 45, and bicarb of 26. What is the most likely acid-base disorder? Answer is respiratory acidosis. So the given ABG results, yes, you have to do the step. Yeah, first is to identify the pH, second identify the primary change, and check the bicarb for compensation. So while doing this, yes, this is a case of respiratory acidosis. So I have provided a small table which helps you to understand easier. So in case of respiratory acidosis, pH will be decreased, PaCO2 will be high, bicarb will be high, and the primary mechanism here is CO2 retention. So each of them, just like this, metabolic acidosis, respiratory alkalosis, and metabolic alkalosis, the values and the mechanism is provided here. Yes. Next, moving on to patient present with chest discomfort and palpitations. ECG shows PSVT. Drug used in prophylaxis is answer oral verapamil, because PSVT is a re-entrant tachyarrhythmia that originates above the ventricles, commonly due to AV nodal re-entrant tachycardia or accessory pathway mediated re-entry. The drug used for prophylaxis is oral verapamil, a class 4 antiarrhythmic agent. Mechanism is verapamil and diltiazem. They are calcium channel blockers, that is class 4 antiarrhythmics. They slow the SA node automaticity. They prolong the AV nodal conduction time. They suppress the AV nodal re-entry, and they reduce the myocardial contractility and BP via decreased calcium influx. So the other drugs and their features are also mentioned here. And next question, a 19-year-old female patient who is a known case of type 1 diabetes mellitus presents to casualty with diffuse weakness. She has stopped insulin one day before presenting as per her mother. On examination, BP was 80/60, plasma glucose was 720, sodium was 126, potassium 4.3. Which of the following is not a step in the management of this condition? Answer normal saline 3%. Here the clinical picture points towards type 1 diabetes, hyperglycemia, hypotension, electrolyte disturbances. They are all diagnostic of the diabetic ketoacidosis, which is mentioned here. So it results from insulin deficiency and increased counter-regulatory hormones like glucagon, cortisol, epinephrine, growth hormone, leading to ketone body formation, metabolic acidosis, and dehydration. Management involves fluid resuscitation, insulin therapy, electrolyte correction, and monitoring, but hypertonic saline is not used. So the stepwise management: first fluid resuscitation is done, then insulin therapy is given, then potassium management is done, and bicarb therapy is given, and then glucose monitoring is done. Next, a 40-year-old male patient presented with complaints of drowsiness and was admitted for evaluation. And guys, diabetic ketoacidosis management is a very, very important question. Even for INICET and Fmge also is very important. Yeah, now question number 13. A 40-year-old male patient presented with complaints of drowsiness and was admitted for evaluation. Sodium was found to be 98, which was corrected to 110 with 3% saline in 24 hours. Patient recovered for a while and had altered centurium later. Now he developed quadriparesis and bilateral conjugate gaze palsy. Investigation to be done in this cases. Answer MRI brain. The patient had severe hyponatremia that was rapidly corrected using hypertonic saline. This rapid correction of chronic hyponatremia can cause osmotic demyelination syndrome, also known as central pontine myelinolysis. The classical presentation includes initial improvement after correction of sodium, followed by delayed neurological deterioration, and the symptoms here are quadriparesis, pseudobulbar palsy, dysarthria, dysphagia, and bilateral gaze palsy. So investigation of choice is the MRI brain. And the pathophysiology is also mentioned. Here there occurs mainly the oligodendrocyte damage leading to the demyelination of the pontine neurons. It is common in chronic hyponatremia, especially in alcoholics, malnourished individuals, and liver disease or transplant patients. Now, next question, a patient with HIV with a CD4 count of 250 is newly diagnosed to have rifampicin-resistant TB. What is the most appropriate regimen and what should be monitored? Answer here is bedaquiline, pretomanid, linezolid, and moxifloxacin for 6 months and immune reconstitution syndrome. The patient is HIV positive with a rifampicin-resistant TB, which is a form of multi-drug resistant TB. The recommended treatment regimen for this condition is the BPAM regimen consisting of a duration of 6 months. So here we have the bedaquiline, pretomanid, linezolid, and moxifloxacin. So the patient should be closely monitored for immune reconstitution inflammatory syndrome after starting the antiretroviral therapy. And IRIS occurs due to restoration of immune function after ART initiation, leading to paradoxical worsening of the TB symptoms. The rationale for choosing the BPAM regimen is also provided here. And next, a patient with type 2 diabetes mellitus complains of numbness and burning sensation in the extremities. On examination, he has absent ankle reflexes and has no sensation to touch, vibration or pain in his lower limbs. The loss of sensation in his extremities has a stocking distribution, What type of neuropathy is associated? Answer is symmetrical distal neuropathy. So the patient presents with numbness, burning sensation, absent ankle reflexes, and stocking distribution sensory loss, all classical features of distal symmetric polyneuropathy, the most common form of diabetic neuropathy. It results from chronic hyperglycemia leading to axonal degeneration and segmental demyelination of the peripheral nerves. So the pathophysiology is mentioned here, and also the clinical features are also given here, guys. In this condition, we usually have the stocking and glove pattern of sensory loss. And the classification of diabetic neuropathy, we have classified it into 3 types, and this is the commonest classification used. It is the symmetrical distal polyneuropathy, autonomic neuropathy, mononeuropathy, and the polyradiculopathy. Next, a patient presents with skin tightening and arthralgia. Raynaud's phenomenon was positive. Lab investigations showed ANA positive and anti-SCL70 antibody. The presence of which of the following condition is associated with anti-SCL70? Answer is interstitial lung disease. So, combination of ANA positivity and anti-SCL70 antibody and skin tightening with Raynaud's phenomenon indicates systemic sclerosis, which is also known as scleroderma. Anti-SCL70, that is the anti-topoisomerase 1 antibodies, they are highly specific for diffuse cutaneous systemic sclerosis. This autoantibody is strongly associated with the interstitial lung disease and diffuse skin involvement. So systemic sclerosis features are present here, and autoantibodies in systemic sclerosis are also mentioned here. Next, a 68-year-old male with type 2 diabetes mellitus and HbA1c of 8.2% is being evaluated. He has chronic heart failure with an ejection fraction of 35% and is currently taking metformin and glargine insulin. Which medication is most appropriate to add for glycemic control in this patient? Answer is empagliflozin. So patient here has type 2 diabetes mellitus with poor glycemic control and chronic heart failure with a reduced ejection fraction. Most suitable drug to add in this setting is empagliflozin, which is the SGLT2 inhibitor. Mechanism of action is it inhibits the sodium glucose co-transporter 2 in the proximal renal tubule, reducing the glucose reabsorption and increasing the urinary glucose excretion. This leads to lowered blood glucose levels, and it leads to osmotic diuresis, which leads to the reduced plasma volume and preload, improving the heart failure outcomes. And also there is reduction in the cardiovascular and renal events. And clinical benefits in this patient, it improves the glycemic control with low risk of hypoglycemia, and it reduces hospitalization for heart failure. It provides renal protection. So next question, a patient presented with right-sided weakness, aphasia and irregular pulse for the last 2 hours. On CT brain, no hemorrhage can be seen. What should be the next step in the management? Answer is RTPA. Here the patient presents with acute onset right-sided weakness and aphasia, which are signs of ischemic stroke. So the presence of irregular pulse suggests AF as the probable cause. A cardioembolic stroke might have happened here. A CT scan shows no hemorrhage, confirming a non-hemorrhagic stroke. So the treatment of choice for an acute ischemic stroke within the Wintour period is IV thrombolysis using RTPA, that is alteplase, and RTPA should be administered as soon as possible, ideally within 3 hours of symptom onset up to 4.5 hours in selected individuals. Next, mechanism of action. RTPA, it converts the plasminogen to plasmin, which dissolves fibrin clots and restores the cerebral blood flow. Early reperfusion reduces the infarct size and improves the neurological recovery. Contraindications and key inclusion criteria are also mentioned here. Next, an elderly patient presents with increased frequency of breathing and weakness. EPG is given. What is the likely diagnosis? So here the answer is acute metabolic acidosis with anion gap of 30 milliequivalents per liter. So the stepwise explanation, guys, you need to practice few MCQs about this anion gap and about finding this acid base abnormality. It is very, very important. Yes. So you can just go through this to have an idea. So the common causes of high anion gap metabolic acidosis is mud piles. You can remember it using that code. M for methanol poisoning, U for uremia, CKD, and D for diabetic ketoacidosis, P for propylene glycol poisoning. Next, I for iron isoniacid toxicity, L for lactic acidosis, E is ethylene glycol excessiveness, and S is for salicylate toxicity. So the normal acid base values are also provided here for your reference. Next, a 35-year-old female with hyperpigmentation, hypotension and hyponatremia is diagnosed with Addison's disease. Which hormone is responsible for her hyperpigmentation? Answer is ACTH. So Addison's disease is caused by the destruction or dysfunction of the adrenal cortex, leading to deficiency of cortisol and aldosterone. Because of the low cortisol, there is loss of negative feedback due to the hypothalamic pituitary adrenal axis. This leads to increased secretion of ACTH and MSH. from the pro-opiomelanocortin, that is POMC precursor. Excess ACTH and MSH stimulate the melanocytes in the skin, causing generalized hyperpigmentation, especially in skin creases, scars, pressure jaw points, and mucous membranes. Mechanism of action is also provided here. Next question. A 65-year-old male presented with fever, cough, and chest pain. Identify the lesion in the given chest X-ray. Answer is right upper lobe consolidation. So chest X-ray shows a homogeneous opacity in the right upper lobe, upper lung zone. Opacity is non-homogeneous with air bronchogram visible, suggesting alveolar filling here. And the right upper lobe consolidation typically appears as a dense opacity in the upper and mid zone and the sharp lower margin, and it may obscure the right upper mediastinal border, and the volume of the lung is maintained unlike in collapse. So the key differentiating features are also provided here, and pathophysiology as well as given. Next, 25-year-old female patient with diagnosed recurrent migraine despite sumatriptan has 3 to 5 episodes per week and presents with features of anxiety and palpitations. There's no clinical neck swelling, no history of coronary artery disease. However, there's family history of CHT. She reports experiencing chest tightness after taking the medication. Most appropriate agent to add for migraine prophylaxis is propranolol. So here the patient experiences frequent migraine attacks despite abortive therapy, that is the sumatriptan. She also reports about chest tightness after sumatriptan, which is a triptan-induced coronary vasospasm side effect. And so therefore, she now requires a preventive prophylactic therapy, not an abortive agent. So propranolol, which is a non-selective beta blocker, is the first line drug for migraine prophylaxis. The drugs used for migraine prophylaxis are mentioned here. You can just go through. And yes, the other drugs also in the options, they have been explained here. Next, which of the following crystalloid infusions when given in large quantities is likely to cause hyperchloremic metabolic acidosis? Answer is NS. So 0.9% NS is an isotonic crystalloid commonly used for fluid resuscitation. Although it is isotonic with plasma, it is not physiologically normal because its chloride concentration is much higher than the plasma chloride levels. When infused in large quantities, this excess chloride load causes a reduction in the plasma bicarb concentration, leading to hyperchloremic metabolic acidosis. So comparison of the common crystalloids is provided here, and the acid-base effect as well as given. And yes, next question. A 14-year-old developed rapid growth and had long legs and large hands and coarse facial features. Which tests are used to make a confirmatory diagnosis? Answer: no suppression of the GH after glucose administration is a confirmatory thing. So clinical features like rapid growth, long limbs, large hands and feet, and coarse facial features, they are characteristic of gigantism. Confirmatory test for growth hormone excess is the OGTT with growth hormone measurement. In normal individuals, glucose suppresses the growth hormone secretion, but in growth hormone secreting pituitary adenomas, this suppression does not occur. So OGTT, OGST, that is the oral glucose suppression test, which is a confirmatory test that is also provided. The details and procedures is provided here, and the screening test as well, and the pathophysiology and the clinical features of gigantism and acromegaly, how they are different, is also provided. Now, next, a patient presents with bleeding due to factor IX deficiency. In which of the following conditions will you find an improvement after administering vitamin K parenterally? Answer is bile duct obstruction. So, vitamin K is essential for gamma carboxylation of certain clotting factors in the liver. These vitamin K dependent coagulation factors include the factor 2, 7, 9, and 10, as well as the protein C and S. Vitamin K is a fat soluble vitamin and its absorption requires bile salts. The mechanism in bile duct obstruction is provided here, and also the other options are also in the question are also explained here. Now that's it. So that was the explained one, and here we have the rapid revision, that is a quick glance through of the questions with mild explanations provided, smaller explanations provided, guys. So I hope you guys are interested in this 3-set subject discussion of the questions, wherein one it'll be just the test format, and then the rapid revision, and also the explained elongated one. And I'll be coming up soon with my next video with my next subject. If you have any queries, any comments, please do mention it in the comment box. And if you're interested in buying my previous Neetpg PYQQ bank, the link is there in the description, and the new one will be uploaded. The volume 1 will be done by Jan, and the volume 2 we are expecting to release it by Feb. And if you guys are interested, you can do the pre-booking as well. So that's it, guys. Till I come back with my new video, stay tuned. Till then, bye.